Today we have with us Dr. Indushekar Subanna, a pioneer in interventional radiology.
Out of all your experience, how do you put it to the patient what you're going to do? How would you define intervention radiology to a patient?
Use local anesthesia for entering into a blood vessel, whether in the groin or in the arm or in the hand. And then it is painless. We normally explain to the patient the entire procedure, what we are going to do, and encourage them to see the blood flow and injection of contrast when everything is flowing inside the body. They'll be able to see that. And so many people who are afraid of looking at the screen during procedure, once they see, they are so much impressed.
You have treated so many patients. It's been a 40-year career. So, is there an emotional moment or?
No, basically, as a doctor, you lose all your emotion. Basically, when you do a good work and patient comes out of pain, that is really emotionally gratifying. We had to do some experimental work on animals like rabbits. Rabbits are like tiny babies, where you have to be very careful when handling them and putting them to sleep by anesthesia, then taking them on the table and introducing a fine catheter and needles, guide wire and all. It requires a lot of patience and skill, both.
Today, do students go through that training, animal training, sir, or was it only back then?
Actually, today you can't have an animal experiment.
Right.
A lot of restrictions are there.
Welcome to Oncoflix podcast. Today we have with us Dr. Indushekar Subanna, a pioneer in interventional radiology and one of the most impactful person in this field of medicine. It is a privilege to have you, sir. Thanks for being on our show.
Thank you.
Welcome, sir.
Thank you.
So in 1986, when you finished your MD in radiology, so interventional radiology was probably a never was a word. So what made you get into this niche specialty and build on this?
In fact, not just 86. In fact, even before that, I had an opportunity to witness a lecture by one Subanna from US, who had come to Bombay when I was doing my post-graduation. He was talking about some drainage system, appendicular abscess drainage, liver abscess drainage, where it was a very primitive, preliminary things to do by Seldinger techniques. And it was very impressive because that itself was a new frontier where you are replacing a surgeon, literally. By doing lesser invasive procedures using imaging, ultrasound, something like that. So that itself made me think about this field. And after finishing the MD radiology in Bombay, I came down to Davangere, where I worked as a lecturer and then became associate professor in the medical college. During that period, I used to do some of the angiograms, diagnostic work basically, and biliary opacification called PTC and things like that, and some of the myelograms. Although they were actually invasive procedures, but it was not a therapeutic one. It was mainly for diagnosis. And that actually, always I had the interest in doing something therapeutic. That means we're handling a patient and achieving a treatment for a particular disease. So from the beginning, I've been interested in intervention radiology. In fact, the concept of intervention radiology came much later. we didn't know that we were doing interventional radiology. Even before that, we were doing some work within the interventional radiology purview.
Interesting.
Having said that, sir, do you remember the first patient for whom you put a cannula, you saw something on the screen, you treated it and achieved a control without surgery, like how you mentioned?
Yeah.
Do you remember the story?
Yeah, in fact, before entering radiology, I was doing a house job in Bombay in neurology. That time, neurology and radiology department, they were doing direct carotid punctures, where you put the needle directly into the carotid artery.
Okay.
And I was exposed to that. When I started radiology and went to the same hospital for my training, without hesitation, I was able to put a needle in the carotid artery and do a carotid angiogram.
Okay.
That is something very unusual, because to get into that kind of a mode where there is so much of fear. Today everyone is afraid of putting needles, but we were dare enough to do that. And that is the beginning, I think.
Cumulative experience of other departments also into radiology.
Well, it's I mean, we had that raw courage to do that
Right.
without thinking the consequences. Really, at that time, it was although it was unheard of, and doctors were doing a lot of heroic things, which we are not ready to do today.
Right.
So that way, we were exposed to certain things which we never thought of as a student.
Right.
So, I mean, you've spent 40 years of your career in what we call as the back room of the hospital, which is the cath lab. Away from, clinics, actual clinics or ward rounds, etc. So, what has, this quiet room taught you compared to the noise what we see in the regular clinic?
Actually, when we go to the cath lab,
Okay.
and we would have actually planned a particular procedure on a patient who requires a particular intervention. You have plan A, plan B, everything in your head. And you know that, okay, well, unless you do this, patient is not going to improve. And every time, every day you go to the cath lab with a different challenge. And it is always very interesting to enter the cath lab. Never feel that, oh, today I should not work, I'm tired, nothing doing. Every day you're so enthusiastic that you want to work in the cath lab. That's a motivation is there.
Because you see different things every day. You see
Yeah.
a different challenge every day.
Yeah. You feel that you have a challenge every day. In fact, this was there from a beginning where I started my actual intervention radiology career in France. There we had two cath labs in the same area with a common control room. So on one side, professor would be doing, on the other side, students would be doing, and I was one of the trainee there. And sometimes the boss used to say, okay, you go ahead and do it. So it was so interesting every day that you have a new challenge. So that way we were given a free hand to do. At the same time, guidance was also there. Somebody is there to, guide you in the right moment if you are going wrong.
Fine-tune your skills.
Yeah, fine-tune your this. And also, fortunately for me, I had to do some experimental work on animals, like rabbits.
Okay.
That's very interesting. In fact, rabbits are like tiny babies, where you have to be very careful when handling them and putting them to sleep by anesthesia then taking them on the table and introducing a fine catheter and needles, guide wire and all is requires a lot of
Yes.
patience and skill,
Skill,
both. So that in fact gave me a lot of
confidence.
skill which develop over a period of time. At the same time, patience.
Exactly.
Today, do students go through that training, animal training, sir, or was it only back then?
Pardon?
The animal training, what you told, needling a rabbit and all. Do
Yeah.
students today are they subjected to such training?
No. Actually, today you can't have an animal experiment.
Right.
Lot of restrictions are there, but now you have something called as Mantis, where you can have an electronic computerized system where you can use the catheter, guide wires and all to enter a particular vessel and do all the interventions like a simulator.
Simulate.
Like a flight simulator, you have the equipments which will be helpful for trainees to get the feeling of catheters, guide wires and other materials related to IR.
Okay. Cadaveric simulators won't help in IR,
No,
right?
basically in IR, you work on tubes.
Right. So it will be
Now in a cadaver, all the blood vessels are
first blocked. Yeah.
so you can't navigate your
it doesn't help.
catheters. Unlike surgical
Right.
techniques in cadavers.
Right.
So it's not possible. The only thing is you have to have a model.
Model
Yeah.
to learn. Yeah. So for a patient, from a patient perspective, radiation, chemotherapy, surgery is something that they've heard of. But intervention radiology is completely a new name to them. So out of all your experience, how do you put it to the patient what you're going to do? How would you define intervention radiology to a patient?
See, normally you have to explain to the patient how the procedure is being done, reassure them, and it's not painful procedure, and you just have to use local anesthesia for entering into a blood vessel, whether in the groin or in the arm or in the hand, and then it is painless. So we normally explain to the patient the entire procedure, what we are going to do, and encourage them to see the blood flow and injection of contrast when everything is flowing inside the body. They'll be able to see that. And so many people who are afraid of looking at the screen during procedure, once they see it, they're so much impressed. Like that, it's not very difficult to convince a patient. There may be apprehension in the beginning, but as the procedure goes on, they are very much relaxed. And we will be talking to them all the time.
Mm.
So, patients feel happy about undergoing the procedure like that.
Perfect. So initially when you started off in a cancer hospital like HCG hospitals, okay, there is maybe 3 pillars of cancer treatment, which is surgery, radiation and chemotherapy. And this is a new branch, interventional radiology. How did your peers take, like the mainstream radiation oncologist or medical oncologist or the surgical oncologist take, when they hear the word interventional radiology, and how did you gel with them, or how did you integrate with these kind of fields to make an impact in cancer patients?
Yeah, basically, what I did is to, for example, in the beginning, nobody would understand what I'm telling. In the sense, doing a procedure and all that. It's a great thing.
How many years ago, sir?
93. 93. Then it so happened that, I'll just give a story. Before I actually joined Ramaya Medical College as associate professor, I had just come from France. And I went to Ramaya Hospital to meet my old friend, who was an endocrinologist. And then we were just, casually talking. And I said, I've done intervention radiology training. He said, what is it about? I told him, see, I do the angiographies, angioplasties, embolizations of blood vessels which are abnormal. Then I do transarterial chemoembolization for liver tumors, biliary stents, and then pancreatic venous sampling. The moment he heard that, he jumped and said, "What? What did you say?" Pancreatic venous sampling for insulinoma. Next moment he said, "See, I have got a patient who has got suspected insulinoma. Can you do it for us?" Okay. Then I said, "Okay." So immediately he contacted the DE and they said, "Okay, you can use the cath lab." So I had brought certain materials from France while returning. So within a week or so, a patient was called and everything was ready. I had to do the pancreatic venous sampling even before they have thought of joining the college. Okay. So I could do that procedure very easily, and then there were so many people watching on that. That's the first patient which I handled in India.
Oh, okay. You were the first one to do it in India.
Yeah.
Okay.
In fact, the concept was only in France and US. Otherwise, there was no concept of pancreatic venous sampling.
Okay.
And insulinoma itself is a rare disease.
Correct.
And then localizing it and then subjecting the patient for appropriate surgery is another. So that way, I was able to convince the other clinicians this is something new which can be utilized for diagnosis and therapeutic reasons. And initially they had apprehension, then slowly everybody realized that these procedures are less invasive, much easier, and can be done in emergency setting. And when there is no way out, interventional radiologists can do something.
Very nice.
Yeah. That's the thing, especially when there is bleeding,
Correct.
intra-abdominal bleeding or hematemesis or whatever. So slowly everybody got convinced about the potentiality of interventional radiology as a specialty.
So when we talk of intervention radiology of a therapeutic aspect, hepatocellular carcinomas is one of the most common indications, and you have robust experience, be it tape, taste, all of that. So tell us your experience of how this has replaced surgery in certain cases and where it has been complementary to surgery. And of course, CyberKnife as we would.
Yeah, in fact, for more than 50 years, transarterial chemoembolization has been the mainstay in management of HCC, hepatocellular carcinoma, more than 50 years. The concept is very old, it's not a new thing, where you know that the liver has got dual blood supply and all the tumors get blood supply from the hepatic artery, not from the portal vein. And the tumors will not have lymphatic drainage with Kupffer cells, so that whatever agent which you are injecting, like lipiodol, will stay in the tumor for longer time. It won't be cleared. So this is a basic principle, and it has been there for quite some time. Before the advent of TACE, there was no treatment for HCC or even in metastatic liver tumor. Practically, there was no treatment. And everything was so hepatotoxic, or toxicity levels for the patient used to be very high. Now, with this, you are able to reduce the toxicity side effects of for the patient, at the same time control the disease. The concept of resection came much later, especially for HCC. Nobody would operate in 80s, 90s. Once they started doing more and more anatomical resections of the liver, they also extended it for HCC.
Okay.
Till that time, taste was the only thing.
So in
Then
all,
meanwhile, what happened was there were other methods of treating HCC where they developed radiofrequency ablation.
yeah,
Then the microwave ablation,
radio
ablation. Then came radio embolization with yttrium,
Right.
all that. So basically, you depend on BCLC classification and the staging at BCLC. Depending on that, you are treating HCCs. So guidelines are very clear now. And in fact, we have a separate guidelines or improved guidelines for Indian patients. Yeah.
So in your experience, which amongst these following procedures that you have told has actually made larger difference for this hepatocellular carcinoma? Since you told TACE has the longest experience and
Yes.
forward, but newer discoveries should have a nuance over the past experience. So which one would
Yeah,
you
it all depends on what stage you are seeing the
Right.
patient. If BCLC-A and smaller tumors, you simply go ahead and do an ablation.
Right.
Or if nowadays what we do is that when you assess the patient for HCC, the resectability is a contraindication for any other treatment.
Right.
Okay. That means if the patient is fit enough physically and the lesion wise, if they are fit for surgery, you are not going to do anything.
Right.
So, in fact, we consider resectability is a contraindication.
Right.
So, what other things are there? Then you are trying to give good quality of life.
Right.
So, ablations are one of the important things. And TACE still now, even now, it is one of the best methods.
Right. So even after years, TACE
TACE stands out very clearly the most important step in managing the HCC. Of course, now radioembolization with yttrium is another, which is very common here. Maybe world over it is becoming popular, but there are a lot of control related to availability of the isotope. But in HCG, what we are trying to do is not to use yttrium as a for radioembolization. Instead of that, we are using lutetium and actinium. And in more advanced cases, so we are now able to treat much more advanced cases where there is no other treatment possible. So, and downstage the disease, then you go for simpler treatment like that.
Right. Okay.
So if you listen to every specialty in a tertiary hospital, take for example cardiology, okay, neurology, or urology, or oncology. If, for example, if you have to supply their audience, how dependent are these branches on interventional radiology, or how much are they based on the principles of interventional radiology in their evolution? Which you feel is, the core principle is interventional radiology, and they have probably taken over.
Yeah, see, the beginning of interventional radiology started with Schildinger technique. Okay, that is the whole basis of interventional radiology, where we put a needle, put a wire through that, and then exchange for a catheter. So that Schildinger technique is the one which actually revolutionized the entire medical management of so many diseases. Almost everything you do with Schildinger technique, be it anchoring a blood vessel or putting the drainage catheter, or a drainage of pleural effusion, or ascites, any vascular intervention, or biliary intervention, everything is dependent on that one particular principle of cellular techniques which is developed by a radiologist.
Yeah.
Until that time, people did not know how to enter a blood vessel.
Okay.
So it is crazy, because you all the other departments developed the navigation into different areas of the body through the blood vessel.
Right.
So unless you make an entry into the blood vessel, where will you? So I think cellular technique is the best example of changing the entire medical scenario by the radiologist.
So when we talk of intervention radiology, what common people routinely know is the angiogram or cardiac related interventions that happen. But even in the oncology space, a lot of interventions that you have done has helped our patients. To name it, embolization. So tell us, sir, one or two patients that you remember where preoperative embolization changed the course, and also when a patient had tumor bleeding, which is one of the common emergencies that we see in oncology, where you were able to pick up where it was and how it made a difference.
Well, actually, the concept of embolization is basically to block a blood flow or a leak. Whether it is in the main blood vessel or from the tumor bed, anywhere. And depending on the location and the type of bleeding, we have to use different materials to block it. Now, in case of a tumor which we need to block, we have to use the smaller particles, which will go and sit in the capillary network. So, the preoperative embolization, what you say, actually when we do that, either in the large kidneys, a large tumor within the kidney or in the pelvis, where the intraoperative bleeding will be high. In that situation, using particles will be best.
Has ever this embolization been used therapeutically, sir, to shrink a tumor?
Yeah. In fact, the concept of tumor embolization came as a part of preoperative workup.
Right.
In the sense, when the surgeon didn't want the blood loss to be happening, so he embolized that so that next day patient can be taken for
safe
surgery without blood loss. At the same time, the transfusion requirement will
come down. Okay.
Then there is another aspect. Post-operatively, if the patient has got a bleeding,
right.
For example, we have done a partial nephrectomy or something like that.
Yeah.
Within 24 hours or 48 hours, patient develops a bleed within the operated area. You can't go back and open easily. Yes. It's going to be much more riskier.
Right.
So, what we do is do an angiography of that area, identify the exact bleeder, and block that bleeder with a coil, embolization coil, so that the bleeding doesn't happen. This has happened several times. I think, in fact, we have even wrote a paper on post-operative bleeds and all.
Right.
Same thing happens when you do a liver resection or any abdominal surgery, pancreatic. So anywhere when the surgery is done, or even when there is a pancreatitis, for example, they can bleed heavily.
Right.
So we just go in and do the embolization. And the other specific area I want to tell you is about head and neck tumors.
Right.
Where there is a post-operative situation where the patient has undergone even radiation, chemotherapy, surgery, everything. Patient can come back with what is known as carotid blocks.
Right.
That's a very, very emergency situation where patient can exsanguinate within no time. So the best way is to do either embolization or put a covered stent,
Right.
where the circulation is maintained and you stop the bleeding. So
Okay.
this has happened in this hospital itself.
Yes, in fact, I remember one of our patients was there in the ICU with the GI bleed. We couldn't locate the site of bleeding. Intervention radiology rightly picked up the area, embolized, and the next day we were able to stabilize. And in the next 3 days, patient came out of ICU. So I don't think any other branch can act at that acute moment, 11th hour, to identify correctly as a niche and come out.
Yeah, actually, I should share my experience in this. Way back in 2003, 2004, when I got a call from Malay Hospital, which is before HCD. I used to work in Malay Hospital. And I got a call around 8 o'clock in the night where I was actually coming back to myself.
Okay.
So I had to rush to hospital. When I went there, I came to know that patient, a young Sardarji fellow who had a motorcycle accident 1 week before. And he was quite stable. And on that particular evening, he had a bout of hematemesis. Immediately, I was alerted. Then they said, we have to do something because this hematemesis is not going to stop. And so, in the emergency embolization was planned, and he was taken to cath lab for the procedure. Before the cath lab transferring, he had another bout of hematemesis. And while I was doing the procedure, he had another bout of hematemesis, massive hematemesis, more than 400, 500 ml. Literally, he was collapsing on the table. So quickly, we could actually do the coil placement with celiac artery, and the bleeding stopped. And he was conscious throughout, fortunately. And next day, when I went for rounds, he himself said, "Doctor Sahab, मैं समझा मैं गया, लेकिन आपने बुलाया वापस."
And that's very true.
Yeah.
That's the kind of gratification you also get when you are doing a procedure.
Right. In fact, these hematemesis could be fatal if
Yeah.
not managed. Right.
It is.
Exactly. No, I mean, probably a decade ago, if at all a patient would come to emergency with, some kind of massive bleed, probably the surgeon would take up for emergency laparotomy, can take one bank in for arrange the blood, and it would have been a real big process and some hours of procedure and getting him out. But now with interventional radiology, within probably around 15 minutes, 20 minutes, you have the finesse. So walk us through your experience over 40 years and how you divided your work with respect to emergencies, with respect to oncology, with respect to multiple
I think
departments.
Yeah. So because I'm working in a oncology center now, I think 50% of my work is related to oncology. But outside, I've been in different hospitals at different times. About 20%, 25% is related to liver disease.
Okay.
Because you have cirrhosis of liver, then you have upper GI bleed because of the esophageal varices and gastric varices. Then you have Budd-Chiari syndrome, like that. So all that requires a different kind of interventions, like what you call as transvenous obliteration of the varices, called Part O or DRTO. Then there is TIPS procedure where you do a transtubular portosystemic shunting for cirrhosis and portal hypertension and that. Apart from liver tumors and biliary work, the biliary obstruction. Then you have a lot of GI bleeds. Then urological interventions. Apart from tumor, again you are doing some percutaneous nephrostomy, antegrade stenting for blocked ureter. Then can say, what is that? For hypertension, you do renal artery,
Yeah.
stenting and all that. So practically everywhere you are having something or the other. Then you have peripheral vascular disease, which is a very, very big branch. I think if I were to be in a general hospital, 50% of my work would be doing managing peripheral vascular disease, angioplasty, stenting,
Yeah.
arteriovenous malformations,
Yeah.
where you do embolization. Then other important thing is actually postmortem hemorrhages.
Right.
Correct.
That is one of the areas which is actually not underutilized, because
PPH.
the obstetrician should realize that any postmortem hemorrhage, there's no point in waiting, giving transfusion, 20-30 units of blood, and then trying to do repeat surgery or ligation of the uterine artery or intra-ileal canal. Within 20 minutes, we are able to control the postmortem hemorrhage. We have done hundreds of.
I think I still remember Dr. Subanna or whatever,
Yeah.
gynecologist as well.
Yeah.
So
She herself had, being a gynecologist, she herself had a
PPH.
post bleed, and she was so happy after undergoing the procedures. It's quite simple. I feel that the government or the concerned authorities should start something like postmortem center which caters to all this.
correct.
Only postmortem center. You don't have to do anything during pregnancy or anything. Any patient who has got a postpartum hemorrhage or amniotic fluid hemorrhage, any complication should be treated in one particular center. So the quality of service will come. Thereby you are also reducing the maternal mortality rate.
Yeah.
This is a very interesting aspect. Starting off a postpartum center.
So you spoke of the indications where we use in oncology, like embolization, stopping a massive bleed, whether it is oncological or not, postpartum hemorrhages, cardiac also. So what is the role of intervention radiology when it comes to neurosurgery? Where does it help?
Neuro, it is a very big area now, especially stroke management. The moment a person is detected with developing stroke, if he is rushed to the hospital where there is a thrombolysis or thrombus aspiration technique within that hospital, where there is a stroke team,
Right.
you can practically reverse the stroke.
Right. Thrombectomy kind of.
Yeah. Active intervention is needed, whether it is interventional radiologist, general, or interventional neuroradiologist,
Right.
wherever it is. I think stroke should take the precedent, just like in myocardial infarction, where
Then-
cardiologists are doing
Yeah.
revascularization.
Right. Revascularization.
Similarly, the stroke also needs the revascularization procedure much more intensely and in an emergent way.
So
Otherwise, they cannot recover.
within how many hours should they do that, sir, if revascularization?
Ideally, less than 6 hours.
6 hours. So it is still doable. It's not that 1 hour window where it's little difficult for people to reach the right shape.
If you look at the history and the way the stroke management is done, some people who have reached the hospital within 2-3 hours, they have completely recovered without any residual disease. But those who come late may have some residual
Damage.
Effects.
deficit. But otherwise, stroke intervention is one of the major things. Apart from that, aneurysm coiling, AVM embolizations, and things like that.
Is there a role in hemorrhagic stroke, sir? Does it help at all?
Well, when there is already hemorrhage, then there is a problem. If there is impending hemorrhage, like in suspected aneurysms,
Right.
this is going to stop, and it's quite a major role in because this is a non-surgical approach.
Right. Right.
So even what is happening is because of the technology which is available, training available, many of the neurosurgeons are turning into neurointerventionists.
Right.
It is not the radiologist. In fact, many of the places, neurologists and neurosurgeons are keen on doing neurointerventions than the radiologists themselves.
Sir, you would have trained most of the, intervention radiologists or even otherwise people who are doing interventions in their respective branches here in Karnataka or even broader. So, have you had reviews from them stating that a certain infrastructure that is deficient, which is not letting them do what probably they might be doing in an otherwise center? So, otherwise, what kind of infrastructure is needed to do good interventional radiology procedures?
I'm really happy to say that HCG has got one of the best cath labs
Yes.
in the country, where we have freedom to utilize all the materials. And students who have gone from here, some of them are in UK, some are in Australia. And they say there's no major difference between what we do here and in UK.
Oh, that's great, sir. But what about
The type of diseases they are treating may be different. But whatever they learned here as basics is still relevant.
That's amazing, sir. That puts you on par with whatever the standard the West holds. But what about peripheral centers in India, sir? Have you had your students go to a tier 2 or tier 3 cities where are they comfortable doing the procedures with the infrastructure that's available there?
Fortunately for me, I am able to implement most of the standardized work. What I learned in France, I'm doing it here.
Right.
That's my fortune. But in the periphery, what happens is lack of equipment is one of the major things.
Concern is there.
Yeah. And also sharing the cath lab, available cath lab with the cardiologist, where they are very busy.
Right.
They will not get the cath lab in time.
Right.
So you may have to do other intervention radiology late in the night.
Right. So somebody may not
Or
have
early in the
paid.
morning.
Right.
So you cannot do justice in
Emergency situation.
Planned procedure is okay.
Right.
But some places you have to do away with only CR,
Right.
where there is no digital subtraction geographic facility.
Right.
For example, in IGOT, that is Institute of Gastroenterology and Liver Transplant, there is no cath lab, but they are doing only with CR. It's not bad, but there are some technical difficulties related to that. It's like, either you run a Maruti car or a Mercedes car.
Right. So on one end we have peripheral centers and cities.
Yeah. Yeah.
So where do you see robotics coming in, sir? Do you see a robot taking over intervention radiology procedures anytime soon?
No, as of now, cardiology, they are using robotics.
Okay.
Especially navigating through the blood vessels but basic thing you have to start
Right.
by hand and then allow the robot to catheterize. So navigation is one thing which here you have to go through the blood vessel, enter another blood vessel and then navigate the curves and all that. In cardiology it is pretty predictable because they got only 2 arteries.
Right.
But interventional radiology is not so. Because there are so many vessels and so many branches and so many variables. So I don't think we have that capacity as of now. Maybe in future we'll have it.
You know, you have treated so many patients, it's been a 40-year career. So is there an emotional moment or some patient who has made you emotional in the cath lab? Has there been a moment?
No, basically as a doctor you lose all your emotions.
Correct. But even then there will be many patients.
Yeah,
where,
there will be many
one
patients.
of 20,000 patients.
Yeah, occasionally we do have.
But do you remember any of those moments? Huh?
Well, basically when you do a good work and patient comes out of pain, that is really emotionally gratifying. And even when there is when you control a bleeder, patient who has got heavy bleeding somewhere, either in the intestine or in case of postpartum hemorrhage. When you do that, it is very, very gratifying because everyone is looking at you. Oh, you are able to stop them. So emotionally, it does affect us to some extent. I think more satisfying emotionally is when you're stopping the bleeding, or when the patient recovers from impending stroke or relief of pain. They are the things which really gives you a kind of emotional kick, I would say.
Perfect, sir. We hearing, AI being replacing radiologists. Okay. Interventional radiology is a subspecialty of radiology. So, how do you think artificial intelligence would impact interventional radiology in the coming decade?
See, artificial intelligence, if you look at, they can analyze certain things, but it cannot improve your skills. Okay. See, as a IR, you have to navigate through blood vessels. So that cannot be replaced by any sort of artificial intelligence. It may give you, like, you have a GPS system.
Okay.
Right. You have directions within the car. So it is tell you, okay, you go there and take a turn at this level. But there is somebody who is actually doing it. It's like that.
Correct.
So artificial intelligence is like a GPS system where it will give you all the clues. But you have to navigate. And maybe it will give you some idea about whether your procedure is going to be successful or not, or patient is going to benefit or not. But it cannot replace the person behind that. No, it's not possible.
So often we see in emergency situation, it is you and your department which has done the imminent work, and we see an outcome difference. May not be directly, patient may not know that it is Dr. Indushekar or the intervention department that has made the difference, because often it is the managing team. Having said that, you are behind the screen heroes. So if somebody today, let's say, has finished their career in radiology, or started their career in radiology and thinking of doing intervention radiology, there are fears like exposure, and probably it's a niche branch, but they may not get the recognition for the work that they are doing directly to the patient. Of course, the results are seen in the outcome of the patient. What would you suggest, sir?
In fact, interventional radiology is not for everybody. Like, if you are after the remunerations, what you are getting,
Right.
It's only that you have a passion to improve the situation. If you have a passion to treat the patient, to do certain things what others cannot do, then only you should come to intervention radiology. Otherwise, routine things is not going to work, because you have to sacrifice a lot. It is from the beginning. Probably if I were to be a regular radiologist, I would have made more money and this one. But the contentment what I have as intervention radiology is immense.
Right.
That's what I consider.
Very nice. So if you're sitting here in 2036 and if you're recording this again, which cancer or which department do you think interventional radiology would own, like how cardiology has owned heart attacks 10 years from now?
If you look at the disease pattern, HCC is going to be very rampant because the viral infections and things like that. That's one of the major killer in future. So managing HCC will be a big burden.
Interventional radiology is going to own the
Yeah,
carcinoma.
literally, we are doing that because majority of the patients are not fit enough to undergo any other therapy. One. The other is peripheral vascular disease.
Right.
There's so much of burden of peripheral vascular disease.
Yeah.
Millions of people in
India
India
have diabetes
Yeah.
as well.
because of diabetes,
Yes.
hypertension, smoking, everything. So these two areas are most important for the interventional radiologists.
Right.
The rest of the things may not be all that. You know, it's like having the cataract surgeon who is going to be more successful than a retinal surgeon.
Right.
It's like more. Yeah.
Excellent, sir.
It was great having you here, sir.
So thank you so much for being on our show. It's been such a privilege discussing the nuances of interventional radiology, such a understated branch of medicine. Okay, thank you so much for your valuable inputs on the same.
Yeah, in fact, it is necessary for us to convince the medical fraternity to recognize interventional radiology rather than the general public or the patient.
Right. True.
Because even in the medical colleges, the concept of interventional radiology has not come.
Yes.
And only for last couple of years, some of the colleges are. And if you look at the number of interventional radiologists available in the country, too small.
Too small.
Too small. Very, very small.
Super, sir. Thank you so much.
Thank you.